Sure. Thank you.
Yeah, I think we'll just go to the next slide, please. So we're going to just touch a little bit on the background and then talk about where we are with case numbers and then talk about what we've been seeing lately in the pediatric emergency department, kind of outside of the typical cough and runny nose. And then go through a few specific cases where we kind of want to spend a good amount of our time today. And we want this to be an open discussion just to talk about challenging or interesting COVID cases and talk about what clinical dilemmas we've kind of run into here. So next slide, please. So I think we all probably can't believe the first case of COVID in the US was just over 2 years ago in January 2020. We all remember in March of that year when COVID was declared a pandemic and all of the stay-at-home orders started rolling out across the country. We're all getting fitted for our N95s. There was no toilet paper on the shelves. People were hoarding toilet paper. Schools and daycares were closing, and everyone was trying to figure out how to work from home on Zoom. People had their little pandemic projects that they were excited about initially, sourdough house projects. Mine was making a stock tank pool for our backyard, which is in the middle picture on the bottom there. A lot of people were growing out their hair. There were some great hairdos. And then we saw kind of a drastic decrease in cases in the peds emergency department. It was kind of like a ghost town. I remember that spring. And then multi-system inflammatory syndrome was first recognized in April in the UK and Italy in 2020. And then a formal case definition came out in May of 2020 by the CDC. And now where we are, we have, a lot of people vaccinated, 5 and up, kind of still working on vaccination for the kids under 5. Kids are back in school, and the volumes, at least in the peds EDs across the countries, have just gone up significantly. RSV and flu are back. Next slide, please. So things have been constantly evolving and changing, and just when we think we have a handle on things, there's a new variant. A lot more people are getting sick. It's been taking a big toll on mental health and kind of testing the resilience for all of us, especially our children who have been, out of their normal activities, inside, more on screens. So a lot of us are kind of here on the languishing area of the curve. And it's tough with all the things that have been going on. Child abuse rates have increased, food insecurity has increased, kids have been missing their vaccines and routine care. And then there's the mental health crisis, where the isolation, anxiety, fear, and grief. CDC found that ED visits for suspected suicide attempts increased nearly 51% among girls aged 12 to 17 in early 2021 compared with 2019. And next slide, please. So we know that, most kids do really well, especially when compared with adults with COVID. And we'll get into the numbers here in a minute. But COVID really causes a broad spectrum of disease, anywhere from asymptomatic to kind of runny nose, cough, fever, to respiratory failure, all the way to severe multi-system inflammatory syndrome with kind of shock and a Kawasaki-like picture requiring ICU level of care. And we haven't just been seeing respiratory symptoms, we're seeing a lot of GI symptoms and neurological symptoms as well. Next slide, please. And so this is from the AAP website as of February 10th. Our kids have been getting hit really hard, especially this past month with the Omicron variant surge. Kind of peak in around January 20th, kind of decreasing now, but we had a new record of pediatric COVID hospitalizations, and I think we've all felt the effects of that. Next slide, please. Thanks. And so over 12 million kids have tested positive that have been reported for COVID since the onset of the pandemic. And cumulatively, that's about 18.9% of all kids. And generally, kids under 18 make up about 22% of the US population. And then you can see New Mexico is above that 20% mark up there. And obviously, cases are underreported due to asymptomatic cases and home tests. Next slide, please. And generally, we know kids do really well. 0.1 to 1.5% of child COVID cases have resulted in hospitalizations. And then mortality is between 0 and 0.01%. And during the peak of Omicron, the PEDS COVID hospitalization rates were about 4 times higher during that period than during a period of Delta. And the kids under 5 who were ineligible for vaccination kind of had the largest increase in hospitalization rates. And then during December of 2021, the monthly hospitalizations among unvaccinated 12 to 17-year-olds was about 6 times higher than vaccinated adolescents. So, you know, kids are suffering from this and dying from this. We're over 1,000 deaths from COVID, pediatric COVID now. And so it is a disease worth preventing, certainly. Next slide, please. So this is a table from the CDC partnered with 6 children's hospitals looking at COVID-related hospitalizations in pediatric patients in July and August of 2021. Divided them into 3 groups: COVID-19 related hospitalizations, incidental COVID tests unrelated to hospitalization, and then multi-system inflammatory syndrome. And they found the majority of patients with hospitalized for COVID were Black, Hispanic, age less than 5, or 12 to 17-year-old. Next slide, please. And of those 713 hospitalized for acute COVID-19, 67% had underlying medical conditions, the most common being obesity and second most common being asthma. So we do know that underlying medical problems are associated with hospitalization and more severe COVID-19 in pediatric patients. And then the duration of hospitalization was also longer for patients with obesity. About half of them received oxygen support, almost 30% admitted to the ICU, 1.5% died. And then adolescents were more likely to require ICU admission and oxygen support when compared with other age groups, and required the longest duration of intubation. And there was a higher proportion of patients with viral co-infection that required oxygen support. And about half of patients 1 to 4-year-olds required oxygen support, which they thought may be related to viral co-infection as well. Next slide, please. And this graph is from the CDC, just kind of showing the 7-day moving average of COVID cases overlapped with multi-system inflammatory syndrome cases. And so the blue is MIS-C or MIS-C, obviously way smaller numbers, but we generally are seeing cases about 2 to 6 weeks after acute COVID infection, but of course that can vary. So we're still seeing this in the EDs, and we definitely want to keep this in mind. And we've also been seeing prolonged fevers and intermittent or recurrent fevers with COVID-19. So definitely something we just want to keep on our radar. Next slide, please. And here's just a reminder of the CDC case definition. Have to have a fever, evidence or clinical severe illness requiring hospitalization, at least 2 organs involved, and then some sort of COVID history or confirmation by lab testing. Next slide, please. And then this is just our multi-system inflammatory syndrome lab testing guideline. We have kind of a 2-tiered approach. Dr. Jolly, Dr. Muller, Dr. Turi, and Dr. Duran worked on this. And so we'll get, if we're concerned, we'll get screening labs, and if they're meeting criteria, then we'll expand those labs. And, you know, I think this is one of the tricky things, you know, if kids are looking sick or, you know, this is when we're wanting to do this. But I think it's also tricky with the COVID PCR test, because those can be positive sometimes for months, and how many illnesses can kids get during that period? So we have to take it on a case-by-case basis and get a good history. Next slide, please. And then here are our MISC totals, about 6,000 total and 59 deaths. And then the age is typically between 5 to 11, and 60% are going to be male here. Okay, next slide, please. And then this is looking at about 5,000 kids 0 to 9 and 12,000 kids 10 and up back in 2020. Some of the symptoms with COVID. And I would definitely say recently we're seeing a lot of GI and neurologic symptoms. So you can see diarrhea, abdominal pain, nausea, and vomiting make up a decent proportion there, but that was back in 2020. Next slide, please. I think the big thing everyone's been talking about lately is COVID Croup. We joke and call this Crouvid, but there's not a lot in the literature on this. There's been some case reports and some case series. One case series described 3 cases of COVID Croup with stridor at rest. And they found that these patients were requiring multiple treatments, at least getting 3 doses of dexamethasone and racemic epinephrine. And that the time from initial dexamethasone to resolution of stridor was longer than we typically see. And there was also another report of a COVID Croup case that ultimately got diagnosed with multi-MISC. So there, it's possible that COVID Croup may not improve as rapidly with typical treatments as typical Croup patients, but this needs to be studied more. Next slide, please. And we've certainly seen some more complicated COVID Croup cases recently. And typically these are caused by parainfluenza, but can also be associated with RSV, rhinovirus, enterovirus, other coronaviruses, and occasionally influenza as well. Next slide, please. And the Wesley Croup score can help guide our treatment. And we're typically treating these just like typical Croup, but being a little bit, there's a range of dexamethasone dosing being a little bit more on the generous end with dosing when we're seeing COVID Croup is the trend I've seen. Next slide, please. And then we've also been seeing a lot of neurological involvement, headaches, seizures, weakness with acute COVID infections. This JAMA neurology study looked at 1,695 patients hospitalized with COVID, and some of those met criteria for MISC. And they found that about 22% of them had neurologic involvement. Most of those were transient symptoms, but about 12% had conditions with encephalopathy, Guillain-Barré variants, cerebral edema, stroke. So, you know, we don't know the long-term effects of COVID in our kids yet, but some of them are getting very sick. Next slide, please. And then, you know, we do know that the people with diabetes are at increased risk of severe COVID, and COVID infection is associated with worsening diabetes symptoms. And there were some findings published in January concerning for increased incidence of new onset diabetes with a history of COVID-19 infections. Next slide.
Great, thank you. Can everyone hear me okay? Perfect. All right, so my name is Emily Bartlett. I'm an emergency medicine physician at Gallup Indian Medical Center, which is an Indian Health Services facility in Gallup, New Mexico. That's about 2 hours driving distance west of Albuquerque. It's a rural facility.
Sorry to interrupt, Emily. I have a couple of quick questions that people have
No
messaged.
problem.
At what point would you get a CRP for a patient if you were concerned for MISC versus anything else? Would it prompt you to do it earlier? Sorry.
At what point will we get a CRP?
Yeah.
If we're concerned about
Yeah.
system inflammatory syndrome? Typically, we're looking at, and we can go back to our hospital algorithm if you want, but typically we're looking at, you know, 3 days of fever without another clear source. And typically they're going to be looking sick.
Okay. And we have a lot of school nurses on right now. What type of education do you think we should be offering parents of a child that they're sending home from school without scaring them to death? What can we offer them as a, you know, some education so they can be aware of MISC without?
Sure. Return precautions are really important. So I definitely tell people to come back in for prolonged fevers if they're having, multiple days of fever, 3 or 4 days of fever, if they're working hard to breathe, not drinking enough, to urinate normally, not acting like themselves. Those are things I usually tell patients to return for, and trying not to scare them, but you can kind of joke about them. Anything else, Dr. Bullard-Barrett?
Right. It's great to give reassurance to people, to tell them that, yes, less than 1% of kids die from COVID. By the same token, statistics aren't worth crap if you end up on the wrong side of them. So I personally err for scaring the hell out of people so that they understand that this is serious stuff.
Yeah.
And
Okay,
with that, Emily, are there more questions, Sarah?
No, that was it. Sorry,
Okay.
Emily.
No problem. I'm glad we had time for that. Gallup Indian Medical Center, Indian Health Services facility, pretty rural, so about 2 hours drive on the highway east of Albuquerque, and we transfer most of our patients by flight because of ground transport limitations. Next slide, please. And I will say I'm presenting this case on behalf of my colleague, Dr. Krista Solari, who saw this patient initially, but unfortunately was not available today. So this is a 5-year-old previously healthy male who was brought in by family due to difficulty breathing. They noted that he had a cough in the morning. By 4 p.m., his mother noted some noisy breathing. At bedtime, he told his parents that he couldn't breathe and was brought to the ED, the emergency department. And his father and sister were noted to have had recent viral URI symptoms. Next slide, please. So these are initial vital signs at triage. He was afebrile, the temperature of 37 degrees Celsius, blood pressure 117 over 84, heart rate 154, respiratory rate 32, SpO2 92% on room air, and his weight was 41.8 kilos. In terms of his primary survey, he had inspiratory stridor present on airway evaluation, was tachypnic, and tachycardic but with good perfusion of all extremities. Next slide, please. So based on this initial presentation, the stridor and tachypnea were noted by the triage RN, and the patient was brought back to the ED resuscitation area. This was at about 9:30 p.m. Next slide. As the patient was getting moved into the appropriate area and was evaluated by our emergency medicine physician, we learned more about him. So he did have a history of childhood obesity as noted by his weight at triage. He had actually received the flu vaccine in this 2021 year, as well as 2 doses of the Pfizer COVID vaccine in both November and December of 2021, and was otherwise up to date on immunizations, had no known allergy, and social history, lives with his mother, father, and 2 older sisters in Fort Wingate, New Mexico, which is pictured here, and the home does have electricity and running water. Next slide. Physical exam, he was noted to be in distress with a hoarse voice when speaking. For HENT, there was no conjunctival injection and normal posterior oropharynx. His neck was supple, there was no masses, but the inspiratory stridor was noted at rest. To observe a respiratory exam, he was tachypnic with breath sounds present bilaterally. There's no expiratory wheezing, and an intermittent barking cough was noted. Cardiovascular exam is tachycardic with a regular rhythm, no murmurs, and extremities were warm and well perfused with a normal capillary refill. He had an unremarkable abdominal exam, extremity exam, and skin exam with no rash, and normal neuro exam with normal strength in all extremities. Next slide, please. So after that initial evaluation, he was given 10 milligrams of dexamethasone and 1 amp of nebulized racemic epinephrine. That occurred at about 10:10 p.m. Next slide. Initial study, this was his chest x-ray, which showed no focal opacities, and no neck x-ray was obtained, although you can see just a little bit of the neck in that image. Next slide. On reevaluation after the first dose of racemic epinephrine, he was continuing to have stridor at rest. So second dose was given at about 10:30 p.m. Next slide. After that, nurses were able to obtain IV access. Of note, it can take longer than in adults to get IV access in pediatric patients at our facility, often just due to less familiarity and comfort with that procedure among our nursing staff. And at that point, labs were sent off as well. Next slide. These are the results of those lab tests. So CBC with a white count of 9.8, hemoglobin 13.8, and platelets of 318. He did have elevated neutrophils at 88% and low lymphocytes, 4.7%. Had an unremarkable BMP and LFTs. Did have an elevated CRP, 0.7, and then a 4-plex swab, so which tests for flu A, flu B, COVID, and RSV, returned positive for COVID. Next slide. So based on that result, the concern was that this was a case of Croup secondary to COVID-19, and attempts to start transferring the patient were made. So calling to the UNM transfer center to make sure the patient could get transferred safely given the ongoing stridor. Next slide, please. And then again, on reevaluation, continued to have stridor at rest, and so a third dose of racemic epinephrine was given at 1:30 in the morning. Next slide. So because we do have limited ground transport capabilities in the area, the patient was transferred by flight, and the team departed the hospital at about 2:30 in the morning. Next slide. And then on follow-up, the patient was actually able to be discharged from UNM around noon the following day. So arrived in the early hours of the morning, and after that did not require any further medical intervention. So had improved symptoms after that third dose of racemic epinephrine. He did receive a follow-up phone call from the GIMC pediatrics team, or excuse me, the Gallup Indian Medical Center pediatrics team after discharge. His mom noted that he had some noisy breathing when asleep, but no stridor at rest. Did not require reevaluation in the hospital, and the pediatrician reviewed return precautions for worsening breathing or severe distress. However, the patient had not had subsequent ER visits after this encounter. Thank you. That's the end of this case. I'm happy to answer any questions or move on to subsequent cases.
Thanks, Emily. I think this case just points to what Lauren had kind of brought up, that the croup we are seeing with COVID, excuse me, is kind of taking a little bit longer than our typical croups to turn around. And in this situation where, for those of you who aren't in New Mexico, you know, Emily's practice is a long way away from the University of New Mexico. And so anytime we're trying to think about transferring kids, we're all really trying hard to keep them in their own community. That's part of our goals as the Child Ready program. And this was a kid where, I'm sorry, 3 racemic epis? That's a very reasonable thing, reasonable kid to transfer our direction. Thankfully, I don't think we've seen much croup COVID turn into pneumonia COVID. I'm curious if other people have seen any kind of end up that way, but most of ours have stayed limited to croup.
I will say, because of the limited response to the first doses of the racemic epinephrine, the team was making efforts to start kind of preparing intubation equipment should the patient not improve or worsen. So I think the anticipated course was not certain. And so luckily this patient did improve, but there was concern at the time that it might be a picture where they were deteriorating and then further intervention either at our hospital or UNM might be needed. So that uncertainty was something that was challenging as well.
And, you know, for those of us old timers, I think the exposure to the cold air and the helicopter flight or airplane flight probably helped settle this kid down as much as all the racemic epi did by the time he got to us. And now it's no longer in the middle of the night. And we all know in pediatrics, everything is worse between midnight and 4 a.m. And it gets better by light of day, magic. So it's hard to know how much of it was our treatment interventions or the natural course of this disease, especially in a kid with croup COVID, because we don't know how that acts yet compared to parainfluenza croup.
How would your care change if you knew it was COVID versus just regular croup, or is it basically the same initial care?
I treat them the same. I'm curious, Dr. Jolly, I know you're on here. What do you think?
From an emergency standpoint, I treat them the same. I would wonder, I don't know if there's any inpatient physicians that are on, because I know there's certain things they do for certain inpatients that have COVID. I don't know if that would change their management at all.
Yeah.
Dr. Scarbeck, one of our other pediatric ED docs, is saying in the chat, yep, same treatment. And that's, I think, how all of us, while we're frightened about, could it get a whole lot worse because it's COVID? I don't think that's really panned out. It's just taken a little bit longer for these kids to resolve.
I do think there have been some studies, talking about lower doses of dexamethasone being just as effective in typical croup. And I think we're not typically using the lower dosing for the croup COVID from what I've seen. What do you think, Dr. Buller-Barrett?
I agree. I still tend to be pretty quick to use the higher dose. Plus, they're bigger kids sometimes, or like Emily's patient who was already a 41-kilo kid. Do we give the dexamethasone corrected for weight? Now just give them 10 milligrams and be done with it. I agree.
Yeah, I was just, because some of our more rural communities, especially when there's that spike in COVID, may have limited COVID testing ability. So at least if they're treating the same, it doesn't really matter if it's COVID or croup with your initial response.
Absolutely. Lauren, you want to go ahead and start presenting
Sure.
the other cases?
Can we go to the next slide, please, Catherine? Okay, so this is a 2-year-old female with history of constipation coming into clinic with a few days of cough, rhinorrhea, and fever. No vomiting, diarrhea, or rash, has been eating and drinking well, goes to daycare, otherwise no sick contacts. Next slide, please. Vitals, pretty stable. Exam was pretty unremarkable. Some mild congestion. Next slide, please. Got a viral swab that was positive for COVID and went home. Later that day, patient developed kind of barky cough and stridor with agitation and fussing, called back the clinic to see if they should come back in. Since they were just in there recently, called in some steroids to the pharmacy. Stridor resolved and then had a total of 4 days of fever. And then the cough and congestion started improving slowly over the next week. Next slide, please. Until about a week later, patient started having fever again. Episodes of vomiting. No recent bowel movements in the past few days, no diarrhea, not eating and drinking as much as normal. And then everyone in the family at that point had a COVID-19 infection with cough and URI symptoms. So fever had kind of gotten better, as well as URI symptoms, and then fever was gone for a few days and then kind of came back. Next slide, please. And then went back to the urgent care. And of course, patient looked great when they went because it wasn't the middle of the night. Vitals looked good. Exam was pretty normal. They gave her some Zofran. She ate and drank a little bit, belly felt soft, so thought symptoms were likely to just acute COVID again, and recommended some Miralax for possible constipation. So she was up again that night with some abdominal pain and one more episode of vomiting, one more day of fever, and then symptoms kind of resolved and was playful and things were getting better. Next slide, please. And then the same patient, about 8 days later, had 3 days of fever, possibly had some diarrhea, but hard to tell because was on Miralax. went to the emergency department after 3 days of fever. The third day, the temperature was up to 104 and not really any other symptoms except for possible diarrhea. And when parents asked if it hurt to urinate, she kind of said yes to everything. So they brought her in again. Next slide, please. So vitals significant for fever, tachycardia, some mild abdominal distension. So with the kind of recurrent fevers, with the COVID infection, provider got the MISC screening labs and then urine. Next slide, please. And the screening labs were pretty normal aside from an elevated ESR. Labs clotted, so didn't get the rest of the studies, but the urinalysis was grossly positive, and so patient was diagnosed with a UTI and started on antibiotics. And so I think we're seeing a lot of prolonged fever with COVID and also recurrent fever with COVID. So it's important to evaluate for other more common etiologies of fever as well, even in the setting of COVID. And just an example of how good return precautions are very important. And so this was actually my kid, and I have pediatric training. So think of how hard this is for non-medical parents with patients with COVID and recurrent fever. We could miss things easily.
Right, and I encouraged Lauren to present her daughter because I just think that's so typical of what we've been seeing with these prolonged illnesses. Is it still COVID? Isn't it COVID? We don't really know. And I think that, you know, for those of us who practice during the winter and non-pandemic months, yeah, we often see these kids with one damn thing after another. And was that the situation this time? Or is this all post-inflammatory COVID? It's not so clear. And I think that kind of one of the questions earlier was, when do you send a CRP? I think we're at the point where if a kid clinically looks well to us, we're pretty comfortable saying, oh, we don't necessarily need to do the labs until they start getting into that 3 to 5 days of fever prolonged. And then I feel obligated because, yeah, you could still have Kawasaki without having COVID. They may not be the same. So when you start getting into those prolonged fevers, even when the kids are looking good, I'm still pretty tempted to do lab studies.
Mm-hmm. Yeah, Dr. Jolly, do you have anything to add? No, he knows this case.
No, but that's why I got labs on your daughter, because I couldn't tell exactly what it was. And fortunately, we found an answer.
Thank you. Okay. All right, this is our last case. So this is a chief complaint was COVID exposure and vomiting. This is a 14-year-old male with a history of asthma coming in with 3 days of fever, headache, sore throat, and then 2 days of nausea, vomiting, and diarrhea, non-bloody diarrhea. And he's had not been able to keep anything down, not drinking well. And grandparents had COVID 3 weeks ago, and he was exposed to them. Next slide, please. Okay, vitals significant for elevated temperature, 38.3, tachycardia, 126. Starting a little bit on the lower end, 91%. Initially, he was kind of laying down in the chair, but sat up for exam and wasn't toxic appearing, but didn't look like he was feeling well. Had some mild diffuse abdominal tenderness, and he was tachycardic. No wheezing on his lung exam. Next slide, please. And so for differential, we were initially, thinking acute COVID-19, a viral gastro, but with him having kind of 3 days of symptoms, decided also multi-system inflammatory syndrome. And so for labs, for workup, we got labs, gave him some fluids, did a chest x-ray, got a viral swab, and decided to admit him to inpatient pediatrics for further workup. Next slide, please. And again, another click, please. Great, and then next slide, thanks. And so this was his initial chest x-ray on admission, no focal opacities, and his heart rate came down to about 97 after 4 hours and some fluids. And his labs came back with a elevated white count, 11.8. His CRP was 18. D-dimer was up. His sodium was low at 129. We didn't have a baseline creatinine for him, but it looked like his creatinine was elevated at 1.28, and he had a elevated bilirubin. His Croup and BNP initially were normal. So he was admitted for dehydration, further MISC workup. His COVID came back positive. His PCR was positive for COVID, and the COVID IgG wasn't back yet. And this was actually about a year ago. So we were kind of waiting final labs, and admitted for dehydration and acute kidney injury, likely secondary to COVID. And that night he developed some hypoxia in high 80s and was started on supplemental oxygen between 1 and 2 liters. Next slide, please. On hospital day 3, on the general floor, he developed hypotension unresponsive to fluid resuscitation with the lowest blood pressure 70/51. So the PICU team came and he was transferred to the PICU. During that period, he developed more respiratory distress and became hypoxic again and was started on high flow nasal cannula. Next slide, please. Labs were repeated. His white count was worsening. His CRP increased from 18 to 21, and now he had a bump in his troponin and BNP, and his COVID IgG came back positive. Next slide, please. Sorry, we have a little delay, but this is hard to project, but his EKG showed some non-specific T-wave changes. Echo showed small pericardial effusion and decreased left ventricular systolic function. That was mild. Next slide, please. And then this is his next chest x-ray, which looks a lot worse. Read was concerning for bilateral pleural effusions, possible worsening pulmonary edema, and underlying infiltrates. So he went up to 30 liters high flow nasal cannula, was refractory to albuterol, ended up receiving BiPAP and Lasix with some improvement there. Next.
Hey, Lauren, there was a question if you know if they did a IgG or IgM for COVID.
They did, and it came back positive, but several days later into hospitalization.
And that was the IgG that came back positive?
Mm-hmm.
Okay, so this really kind of fit more into a non-acute presentation MISC sort of situation.
Yes.
Okay.
So so ended up getting diagnosed ultimately with myocarditis and multi-system inflammatory syndrome, and got aspirin, IVIG, remdesivir, steroids, and his troponin and BNP improved, and he ended up being hospitalized for about 9 days. But I think this was also a good example of, not necessarily an acute COVID infection too, turning into something different. And I think this case was caught really early, and he ended up decompensating when he was already admitted. So I was really glad that we got those labs on him. Next slide. And this is February 2020, right before the pandemic started, and then this year in February of 2022, my little girl. So kids are resilient. That's why we love taking care of them. And thank you all for this opportunity. And we'd love to hear about any other challenging cases or take questions. Thank you.
Thanks, Lauren. That was a great update. I'm just curious if any of our other participants have seen any of the neurologic issues with COVID. We've definitely had a few. And one of the things that I discovered was our lab isn't excited about testing CSF for COVID, but with some assistance from the pediatric infectious disease docs at our facility, they can and are able to do that. I don't know if it's officially reliable, but I've had 2 kids who presented with just acute onset encephalopathy with fever and acute infection with COVID, and they both resolved within 2 days, completely normalized and went home.
So there's a question in the chat. Do you guys see any focal signs and symptoms with MIS-C, or is it more general like encephalopathy? So like focal.
Yeah, the ones I've seen have been the encephalopathy, but I do know that early on in the pandemic, we had, and I think it's been published, a case of a kid who presented with truly transverse myelitis from COVID. But that's about the only really specific neurologic, focal finding type thing that we'd seen, Jason. And Jason, with you here, are you guys seeing a lot of the Croup as well at your facility?
I don't know if you guys can hear me. I think we've just seen 1 or 2 cases of the Croup. But we did, the case we saw, my colleague called the ED and talked to a provider there, probably Dr. Jolly, because he seems like he's always there, but it might have been somebody else. And got a really great rundown on how to take care of that kid. And I think we were able to take care of them here. I don't think it was a formal child-ready consult, but we love to call pals and talk to the PDD.
Right, and for those who are joining us from our New Mexico Child Ready group, obviously, if you got concerns or questions, the telemedicine is always available to you. And we're happy to see the kids to try to decide, do we need to transfer or not? Our goal is always, hey, if you've got the resources, yeah, you should take care of the kids. But if you're starting to get worried that there is going to be true airway compromise, I'd rather see them sooner than later.
And I have a question for some of our Illinois or other states. We have just changed our mask mandate as of yesterday, meaning that the schools have also said children do not need to wear masks in school. They've made that optional throughout New Mexico. What are the mask mandates like in your states, and what are your numbers like when it changed, when the mask mandates changed? What are we in for?
So our mask mandate changed last Friday. So this was the first week, and it was through a court case that it changed, and it's not like an official governor's mandate, but most schools stopped wearing masks, at least in our area, this past week. So it's a little too early to see what's happening, but we had gotten really, really low with cases in our schools. We'd gone from like 144 in one school down to 8 within a month's time. So I am kind of curious now with the mask mandate ending, if those will start to tick back up, but it's a little too early over here in Illinois.
Yeah, and there's some other stuff saying that it's only recent changes as well. So,
well, and I think, when you look at things, I kind of am curious, and I don't know that there's data that supports it one way or the other, but by the time Omicron showed up, most of the kids were back in school, plus minus masks, depending, whereas when Delta rolled through, kids were really being isolated. They weren't in school. And so, yes, we know Omicron tends to be a bit more contagious, but I think we did a damn good job of protecting our kids during the Delta because we were still so aggressively doing our public health, play, which, people have gotten exhausted and have dropped it now. I'm worried about what comes after Delta. I admit it. I'm kind of the naysayer. I think that, COVID is a disease in evolution and will continue to be for some time.
So we still get our influenza vaccine, and we're 100 years out since that appeared.
Right.
Sorry on that uplifting moment. Any other questions out there?